Okay, I agree. Some of you are watching this video wondering to yourself why you're watching a video on OB ultrasound when you don't do obstetrics. Well, if you work in the developing world, either scanning or seeing patients, eventually you will come across a pregnant woman, and that pregnant woman may have complications, and you're going to need some rapid information. And for those of us who don't do obstetrics, we want to know when there's a problem heading our way. This is a case in point from West Africa. This is a woman who had no prenatal care. She had an unknown due date thus, and I didn't know if she was early or late. I was working seeing malaria, and she indeed did have a 4% parasitemia with Plasmodium falciparum. I put the ultrasound probe on her abdomen, and there was fetal distress. The fetal heart rate was less than 100. And then I noticed a low-lying placenta by ultrasound. Actually, the placenta was over the lip of the cervix. We had no ability to do a C-section. There was no surgeon. There was actually no surgical suite. There was no blood available. I tried to get her transported to another hospital about 5 hours down a bumpy dirt road, and the person with the only car in the village said, "I'm not taking that woman who's pregnant. The last time I did that, they delivered in the back seat. She almost died and bled all over the car." So the driver refused to take her. So there you are with a woman who has impending delivery, has major problems that you can see by ultrasound. Now, what do you do? I think part of the answer is just recognizing that you may be in trouble. This actually had a good outcome. I used the ultrasound and found out that there was a singleton pregnancy. The child was in vertex position, and the head was engaged. The baby was alive and moving, even though the heart rate was 100 to 120. I measured the femur length, and it was about 39 weeks gestation, so I wasn't really concerned about premature birth. I could monitor the heart rate with the ultrasound, but I didn't exactly know what to do with that troublesome lip of the placenta across the os. But indeed, all turned out well. The baby actually was delivered. We had to resuscitate him a little bit, but the patient didn't bleed as I had anticipated. So the ultrasound really helped me to understand what we were facing and what we might be dealing with. For those of us who are non-obstetricians, I want to make this as simple as possible. In the first trimester, there are really only 3 questions you need to answer. The first is the patient pregnant? If the patient's not pregnant, then obviously you don't have to worry about the pregnancy. The second question you would like to answer is, where is that pregnancy? Is it intrauterine or is it outside the uterus? Obviously, if it's outside the uterus, you're headed toward trouble and you need some help. The third is, how many babies are there? Are there 1, 2, or 3? In certain parts of West Africa, twinning and triplets are actually extremely common. And you'd like to know that because as you go down the road with this pregnancy, obviously twins or triplets are going to be much more complicated to deal with. Now, discerning whether the pregnancy in the uterus is normal or not may not be as easy as you may think. On one side, we have a normal endometrium in a non-pregnant patient. On the other side, we seem to have something inside the uterus. Is that a gestational sac, or is it a pseudogestational sac? Sometimes it's hard to tell. Let me refer you back to the lecture by Dr. Zavaios on first trimester pregnancy, so you get a little bit more information on how to determine the difference between a sac and a pseudosac. Sometimes, as in this case, you can actually magnify the ultrasound image so that you can see inside the sac. If you look carefully, this is indeed a fetal pole, so this is an intrauterine pregnancy. This pregnancy is a lot easier to see. You actually see a yolk sac, and you see a fetus, and you see the vitelline duct connecting the yolk sac to the fetus. So this is a normal, healthy first trimester pregnancy. What we would really like to know is this a normal intrauterine pregnancy, or do I need to be concerned about an ectopic pregnancy? In this particular patient, we start by scanning the uterus, and you can see that there's nothing in that uterus that looks like an intrauterine pregnancy. As we continue our scan, we see what looks like a normal ovary, and just inferior to that ovary, there's something that shouldn't be there. There's a mass inferior to the ovary. This should raise our suspicion for ectopic pregnancy, and actually this patient has a tubal ring, which tells us that this is most likely an ectopic pregnancy. In this particular patient, if you look carefully, there's actually even a fetal pole within inside that tubal ring. Now, the third question we'd like to answer in our first trimester scan is, how many babies are in there? If you look at the video clip, you see not one, not two, but actually 3 fetuses in this intrauterine pregnancy. And this happens to be a wife of one of my friends who lives in a very remote rural area of West Africa. I was able to estimate the gestational age from the crown rump length, and you can see it was about 6 weeks, 5 days. And I was able to calculate her due date. So my recommendation to them were, let's get you to a referral center early on in your 3rd trimester pregnancy so all 3 of these babies can be delivered safely. Although a little bit beyond the lecture on simple obstetrical ultrasound, I do want to make you aware of several things that are a little bit unusual when you scan around the developing world. The first is molar pregnancy. Well, molar pregnancy is fairly uncommon in the United States. But when I come back to the United States after having been in Southeast Asia or Asia for several weeks scanning, I always say, guess what I saw? I saw 1 or 2 or 3 molar pregnancies. And there's always some degree of disbelief. You see, in East Asia, South Asia, or Southeast Asia, the incidence of molar pregnancy is actually several times the incidence in the United States. So be on the lookout for it if you are scanning in Asia. Something we need to keep in mind when we're doing obstetrical ultrasounds in the developing world is that many women live in malaria endemic zones. On this slide, on one side, we see a positive rapid diagnostic test for malaria. On the other side of the slide, we see a fresh Guimes stain. For those of you who know about malaria, if you look at that smear, you'll see what's called an accolade or an applique form on one of those cells. And underneath that applique form, you'll see a small ring form as well. That tells us that this pregnant patient has Plasmodium falciparum malaria, and that can really complicate things. We know from the epidemiology of malaria that up to 40% of the world's pregnant women may be exposed to malaria. This leads to all sorts of problems. First and foremost, of course, may be anemia, and I have seen women ready to deliver with hemoglobins as low as 2.5. Hypoglycemia is very common in malaria, and that may also be a complicating factor. And of course, severe malaria causing pulmonary edema or cerebral edema is a problem in and of itself. Maternal death from malaria obviously also leads to neonatal or fetal death. On the fetal side of the equation, there's often fetal distress, as was the case that we discussed at the beginning of this lecture. There may be premature labor, but most often what's cited in the literature is low birth weight. And certainly malaria is a risk for low birth weight infants and increases morbidity and mortality in children. It may also be possible if you diagnose malaria or if you have a pregnant woman in a malaria endemic zone to use what's called intermittent preventive therapy, which means that you treat women in endemic zones with malaria medicines several times during their pregnancy, and this decreases the complications we have from having malaria during birth and delivery, and may indeed even contribute to increasing the birth weight of infants in malaria endemic zones. As in our first trimester scan, there are really only 3 questions that we absolutely need to know in 3rd trimester for those of us who are non-obstetricians. The first is, what's the presentation? Is it a vertex? Is it a footling breech? It's nice to know that if you're going to be delivering this baby and you don't have much obstetrical experience. The second thing you want to know is, where's the placenta? If the placenta is over the os, then you're going to have a lot of bleeding, and you better be prepared for it. The third is the baby alive? Is the baby doing well, or is it like that example that I told you with fetal distress with a heart rate less than 100? When we talk about 3rd trimester scanning, we're really only looking for 2 or 3 things. Of course, we're going to use our abdominal probe, and we're going to set our machine on obstetrics 3rd trimester. The reason we do that is if we need to take measurements, the machine will do that for us. Now, there's a real easy way to scan for 3rd trimester pregnancy. We're going to put the ultrasound gel in a circular area around the abdomen and begin scanning from left to right, although you could do it the other way. And we're going to do a quick pass through the scan from left to right, and if we do that, more or less that we see just about everything we need to see. The things that we're looking for is we want to know where the head is, and you can see there's the head down in the pelvis. So the baby is engaged in the pelvis. And as I move the ultrasound probe up, if I angle a little bit, you'll see a 4-chamber heart, and we know that the baby's alive. So we know 2 things of importance already.
is that the head is in the pelvis and engaged, and we know that there's a good, strong heartbeat, and the baby looks like he or she is doing well. We continue to scan around. We want to find the location of the placenta. And if you look at the area where my probe is, you'll notice the placenta is underneath my probe. So it's far away from the cervical os. So we don't have to be concerned that the placenta is going to get in the way of delivery. And as we go around, we see other structures that are really beyond this lecture, but you can see the bladder there, which is that big open dark area. We scan through the abdomen, there's ribs on top, and finish at the bottom. So really, we have completed an entire scan for third trimester pregnancy. We know that the baby's alive, we know the baby's head down, and we know the position of the placenta, and we have a good, strong heartbeat. And for our third trimester simple scan, that's about all the information we need. I'm going to measure the femur length in this third trimester pregnant patient. It's always nice to know what the gestational age is and how long the patient has before delivery, although your first trimester measurements are most accurate. In the third trimester, the femur length is going to be your most accurate measurement. For the femur length, try to get it perpendicular to the beam, and I will measure it, staying away from the epiphyseal plate from one end to the other. And you can see on the machine we're about 33 weeks, 3 days.
Well, you'd like to know where the placenta is. This is actually not my image, but an image from the AIUM OBGYN curriculum, and I thank them for that image. And you can see here that there's the placenta previa, and the placenta is completely over the internal os. This is a scan that I did, and if you look carefully, you'll see that the placenta is completely over the internal os. I did this scan in a very rural village in the developing world, and I will tell you I wanted no part of this, so my decision at this point was to try to get the patient to a tertiary center or a center where they could do a C-section as fast as I could. The last question you want to answer in your simple third trimester scan is the baby alive? And is it doing well? And you can see from this video clip that the heart is actually beating quite nicely and the baby seems to be doing quite well. If you want to be a little fancier, you can drop an M-mode line down through a 4-chamber heart and you can measure the heartbeat. In this case, it was 152 beats per minute, so the child seems to be alive and well. Now, I hope I've convinced some of you skeptics out there, those of you who don't do OB and those of you who don't do OB ultrasound, that there are some simple ways that you can make a profound difference to the pregnant patient in resource-limited settings. There are really 3 things we want to know in first trimester pregnancy and 3 things we want to know in third trimester pregnancy. In first trimester pregnancy, we want to know, is the patient pregnant? And we want to know where that pregnancy is. Is it intrauterine or is it ectopic? And if it's ectopic, it may bleed and threaten the mother's life. How many babies are there? Because certainly if there are twins or if they're triplets, that makes the pregnancy a lot more complicated. In the third trimester, there are 3 other things that we want to know. What is the presentation? Is this going to be a vertex presentation or is it going to be a breech presentation? And where is that placenta? Is it low-lying? Is it overlying the os? Is it a complete previa? Is it going to bleed when the patient delivers at home with a midwife in a little village? Is there a problem on the way with that bleeding? We also want to know, is the baby alive? Is the baby doing well? Is the heart rate under 100, which tells me that there's fetal distress? Or is the heart rate in a good range? And is the baby moving around? We also need to remember that there are some special circumstances that we might come across in the developing world. Especially in Asia, is there a molar pregnancy? Because we know that molar pregnancies are much more common in Asia. We also want to be aware that malaria during pregnancy complicates the pregnancy, both from a birth and delivery perspective and also from a neonatal perspective. Well, a little bit of learning now can go a long way to helping your pregnant patient in the future. This is Dr. Ted Kuhn, and I hope you've enjoyed this lecture, and I hope from now on you'll go ahead and scan those pregnant patients. Thank you very much.